Hi, everybody. Welcome to our talk. My name is Sofia Noori, and I'm here with Isobel Rosenthal and Martin Rosenzweig. As you can tell, we are all psychiatrists, and we're really excited to give this talk today. It's actually a continuation of a talk that Isobel and I gave 3 years ago in the beginning of the pandemic during the first Going Digital. And we had focused on different issues in mental health that we see as clinicians that still have a ton of white space and where we'd really like to see new ideas and new solutions pop up. We'd love to also start with introductions.
Okay, I can go ahead. Really happy to be here. This is such an amazing conference. As Sofia said, we were delighted to be here 3 years ago. I'm very excited to be back. I'm Isobel Rosenthal. I am an adult psychiatrist and also a child and adolescent psychiatry fellow. Yeah, very excited to be here.
Yeah. And I'm happy to also just give a brief introduction to my background. So, in addition to being a psychiatrist, I'm also the co-founder and CEO of Nema Health, which is a venture-backed startup focused on trauma and PTSD care. I'm also faculty at Yale currently, and also serve as a perinatal psychiatrist for the state of Connecticut. Go ahead,
Hi,
Martin.
everyone. I'm Martin Rosenzweig. So I'm sort of new to this panel, but certainly this is an area of intense interest for me. So I'm also an adult psychiatrist. I was formerly the chief medical officer for one of the large payers, but I have over 30 years of experience in really working with sort of large population health and trying to understand how we can innovate and bring solutions, particularly as I think stigma has dropped for a lot of people with behavioral issues, and the system is challenged to find ways to address their needs.
Thanks, Martin. And we're really excited to have you as part of this psychiatrist crew. So today we're going to go through conditions, population segments, and also systems issues that we see within mental health that we would love to see more solutions and innovation around. So we're going to each start actually by talking about a specific condition, segment, or systems issue, and then also kind of open it up and make it into a little bit more of a conversation as well, so that you can hear a couple different perspectives on these issues. So we're first going to start out with different conditions, and I will let Martin take it away from here.
Sure, thank you. So, this is certainly not a new condition. And I think, for many of us in psychiatric training, this is one of the things that, we're confronted with dealing with patients that may have really challenging behaviors. By borderline personality disorder is certainly not uncommon, certainly found more in females than males, and is one of the drivers between intense and expensive psychiatric treatment, particularly around sort of destructive or self-destructive behaviors. One of the areas where I think that is going to drive the need for innovation in this area is, CMS recently changed what they would approve in terms of screenings. And one of the conditions that they will pay for screening is for borderline personality disorder. So there is the potential that more of these patients are going to be identified, in primary care settings. And there really isn't an easy way in terms of where you can refer those patients from a continuum of care perspective. There is a relatively effective treatment for this, cohort of patients. I think the issue, though, is, most people think of DBT or dialectic behavior therapy, Marsha Linehan's sort of work. There are other treatments as well. And this is really the white space because given, the need, the fact that they're often undertreated, they can be high cost patients, the ability to find a way to sort of scale treatment effectively and really sort of manage and help these patients cope better and be more effective, I think the potential is huge. So, it's just, I think people have not really dived into the space because of some of the concerns, but I think the opportunity is huge.
Yeah, I would agree. And just for folks listening, just to back up for a second. So BPD, borderline personality disorder, is a disorder and condition where folks generally can have suicidal ideation, self-harm behaviors, really unstable self-image, and have just like a really chaotic like mental landscape and they often get that, these are the patients that get labeled as like difficult, right? Like in healthcare settings, they generally really utilize care quite a bit. These are the types of patients that are often labeled like dramatic and basically like written off, I think, by a lot of providers as well. And I think one of the reasons why we don't see more in this space is because there's still a lot of stigma around this condition and around addressing it for a lot of providers.
Yeah, I think really interesting points. It's so exciting to be in this discussion. I think one other point too to mention is that these patients often get kind of mistreated with medications. They're often tried on multiple medications that sometimes don't work. They're often misdiagnosed. And a lot of people who suffer from this condition also have a high correlation with early life trauma, which sometimes isn't addressed as well in their treatment.
Yeah, great points.
Right.
So I think, this is another condition state that I think is of growing interest. And part of it really has to do with, these sort of behavioral addictions. And I want to make the distinction between substance addictions, alcohol, opiates and pharmacologic agents like that, versus these are sort of behaviors like gambling addiction or disorders. Some people have published some research around, sexual addiction or internet gaming addiction. So the behavioral addictions are those sort of behaviors that people really kind of get drawn into, and they're unable to really stop themselves to the point that it starts to impact their functioning. For example, with gambling, they may spend more money than they have. They may put their family at risk and so on. The gambling addiction is really recognized by the DSM-5. So it is a reimbursable condition. If you look in the appendix of the DSM-5, you'll see that one of the areas they're looking at is really that sort of internet gaming piece as well. So again, there's a lot of stigma and shame attached to this. There are also treatment options over here that may be helpful, but part of the struggle is that to some extent there hasn't been enough research in this area. So a lot of the treatment is sort of focused where we were with chemical addiction, 30 years ago, with sort of 12-step self-help groups. And really, this is another area, I think, with the right resources and someone who's willing to be innovative could really come forward with a treatment that would be life-changing.
Yeah. I completely agree. I don't have anything to add to that. That was great.
Me either.
So we had a hard time actually titling this slide because there's actually a lot under this, and we ended up titling it psychosomatic disorders. So these are conditions in which there is a real overlap between mind and body that is sometimes really difficult to actually describe. So there are some illnesses such as like a somatic symptom disorder, right? Which is when sometimes the mind can actually produce physical symptoms that are real, but are, in response to psychological distress. There's also functional neurologic disorders where folks like sort of like a PNES, psychogenic non-epileptic seizures, that have like a physical presentation, but are often due to psychological distress. And then there's also just like some poorly differentiated like physical conditions too, like chronic pain, fibromyalgia, even sometimes like irritable bowel syndrome as well, that also have a really large like psychological component that definitely worsen, right, when people are stressed or are having some type of mental health condition. And what's really tough about these disorders is that they're really hard to treat because often these folks present to primary care and to medical professionals who then, part of the etiology is psychological, then send them to a psychologist or a therapist or a psychiatrist. And then, but these folks believe that, these conditions are physical, and a part of it is, right? And so they never quite, their care gets really fragmented. They never quite get the care that they need. And there's actually still like significant research that needs to happen for these disorders to find like good treatments for them anyway. And so the best treatments that we have for them are like a multidisciplinary sort of approach that often never happens. And these patients, frankly, just like languish because they're like high utilizers. They get passed between providers, right? And then there are certain types of therapies that can be helpful for them, like CBT, things like that, but really need like an integrated care approach because these folks need help in different ways because these are like mind-body disorders, right? And so I think there's still a lot that needs to happen for patients who suffer from some of these issues because the best way to treat them would be like a multidisciplinary integrated care approach that I think we just really haven't seen aside from like a couple different centers around the nation. Anything else, Isobel and Martin, you would add?
I don't think
No,
so.
I think you've covered that.
Yeah. Okay. Thanks. So the other thing, and I know that there we've seen some more activity in perinatal mental health from different companies, but I mean, still, I think there's actually like a lot of white space in perinatal mental health because it's such a big problem still. And it's a really like critical period of time for both, the pregnant person and the child. We know that perinatal depression and just perinatal mental health issues are way more common than people give it credit for. It's really not just baby blues. There's so many other types of perinatal associated issues that happen, including depression, but also like trauma related symptoms, right? Psychosis, like perinatal anxiety that can then develop into OCD and things like that. But the problem here is that it's a really critical window where people need to access services pretty quickly to change outcomes for both for the pregnant person and the baby. And because the access is so poor, I've seen waitlists that are actually longer than gestation, that are longer than people's pregnancies, which really can't happen. And so I think there's still a lot that needs to happen around scaling solutions like that extend the reach of providers because there really aren't enough perinatal psychiatrists out there. Like, for example, I live in the state of Connecticut. I'm one of 4 perinatal psychiatrists in the state. So there needs to be a lot more, like, I think collaborative care models, models that utilize and upskill different types of providers to provide support and counseling to increase access in this population.
And I think the other piece over here with perinatal is that you have to recognize that in terms of the risk of developing psychiatric illness, it's much more likely in that peripartum period if a woman is genetically vulnerable. And also, because mood disorders are more common in women than men, there is a large percentage of women who go into pregnancy either having had an episode or at risk. And there's, you also have to sort of support their sort of obstetrics team because, the problem is there's so much concern even around giving advice to like what medications are safe to continue in pregnancy. Unfortunately, the FDA labeling system is not helpful because many of the drugs just fit into what's called a category C, which basically says they're neither dangerous nor safe. So it can be very difficult to sort of help a pregnant woman understand, what is the upside versus downside of stopping or continuing medication and the risk to the developing fetus. So the solution here is not just sometimes focused at the patient; it's really at the care team that's going to take care of this, this woman and her family. And the other piece is sort of interesting. There's some really novel solutions that came out specifically around postpartum depression. With brexanolone, which is a drug that was actually developed by the National Institute of Mental Health. A woman gets the 60-hour infusion and it often treats their depression very quickly. The problem is the system doesn't have a way to actually deliver an infusion for 60 hours to a newborn or to a new mom. So, we have a solution, system doesn't really know how to deliver it, so it doesn't get used. I also believe that, there are these piecemeal solutions. They'll offer therapy, or they'll, meds if need be. You really need something end to end that can sort of manage the entire severity of conditions in this population. And that's, this is really, there's huge need in the space and incredible, I think, opportunity to come up with something that is seamless from a patient experience point of view.
Yeah. Thank you. Yeah, I think the thing that stuck out, to me, hearing both of you speak, is that there's both a lack of access and then just a lack of education among providers. And that's a structural issue that needs to be solved and that technology could help with too. So I think that's really interesting.
Yeah.
All right.
So now we're going to talk about different segments or populations that still haven't been served well by digital health. And I believe that Isobel has the first one.
I do. So everyone's favorite population, teens or tweens. And so, as a child psychiatrist, this patient population is very dear to my heart. And the COVID pandemic was undeniably hard for everyone. But it really had an immense impact on children and adolescents who were not able to go to school for many months on end, and also were deprived of, social interactions, which are important for everyone, but also so important at this age when, there's a change in people's bodies, in their minds, chemically, in their relationships, and in their behaviors. As a result of the pandemic, there have been surging mental health needs. And, besides COVID, there also have been surges in cyberbullying. There was, I think a reliance on social media for connection, which is not necessarily bad, but also comes with other complicating issues. And there's now also awareness of the changes and problems going on with our climate that will affect this generation probably like no other generation before. And all of these issues are things that these tweens are navigating along with their growing bodies and minds. Just a reminder of some statistics around this population. So suicide is now the second leading cause of death for teens. There's an immense shortage of child and adolescent psychiatrists, similar to the perinatal population, where there just really aren't enough specialists in this field. And so now there is, a huge shortage of outpatient resources along with inpatient. I'm sure everyone's seeing photos of, hospital ERs saying things like, children and adolescents are waiting for weeks on end to get inpatient beds. And, unfortunately, the emergency room is not always a therapeutic place. So to kind of have an inpatient hospitalization in an emergency room instead of an inpatient psychiatric unit is really an issue. We think that, we're so excited to see that people are excited about this age group and are innovating, but we still think there are a lot of pain points for this population that need to be addressed, including rapid access to psychiatric services for this population, home-based services, peer counseling, and really, we can't think of the tween without thinking of the family unit. And to think of them as individuals without a family is not the correct way to think about treatment. So we really have to think about treatment that involves the whole family and also involves, the parents as individuals as well.
I just wanted to also define what we mean by tweens, because I think that is a word that's used in a lot of different ways, but we were really thinking about kids between the ages of around 10 to 14 who are going through puberty, also getting access to social media for the first time, right? And in a really critical age where they're starting to also learn how to socialize, not just in person, but on the internet too, while they're actually going through puberty and hormonal changes. So I think there's a lot of opportunity during this age and, this critical window to really provide solutions that will help help teach these tweens how to manage their mental health, not just during these years, but throughout their whole life.
Yeah. And I think to the social media piece, social media can be amazing. It can also be harmful, but it's really important to kind of educate this population on proper social media hygiene so they're not putting themselves in risky situations.
Yeah.
And I think we have to keep that in mind as we innovate and use social media as a way to engage this segment of the population. So next, kind of continuing thinking about development, is this idea of neurodivergence. So this is a term that's kind of used a lot in the media. So again, just to define it, it just refers to this concept that people have diverse ways of thinking and learning within the general population. This term is often kind of thought of when we talk about conditions like autism spectrum disorder, ADHD, different learning disorders. Most of these disorders do manifest in childhood. They're often first identified when children reach school age. And again, as we talked about, psychiatric services are already so limited for school-age children, especially for autism spectrum disorder. So, it's important to just understand how prevalent this disorder is. It affects roughly 2.5% of the population. And nearly 30% of those who have ASD have not received the care that they require. And as of 2020, there was a study out of RAND that showed, of over 8,000 behavioral health facilities, only, less than 13% had providers with specialized training for autism spectrum disorder, and that there were very few specialized programs. And, I think this just brings up this point that there actually are great treatments and programs and ways of going through education for people who are neurodivergent, but they're often really hard to access. And there really is such a need for innovation and for more services in this space.
Yeah. And I think there's a piece here to think about as well, which is, particularly with autism spectrum, the school systems and so on may be set up, and we have services for sort of younger kids and school age, but, they grow up to be adults, and to some extent they age out those systems. Yeah. So what do you do with a sort of relatively high functioning or sort of minimally impacted individual with ASD who needs some help with how they navigate, being in the workplace or, managing sort of social interactions? There are really not a lot of programs, to have the assumption that somehow, because they got this care when they were teens or young kids, that they know how to navigate adulthood. Again, I think that's an underserved area. Let's face it, as adults, when we're in our early 20s, we need help navigating that time. So, on top of having a chronic sort of, issue, I don't think there are enough services that really look at that sort of higher functioning ASD population. And part of it, we talked about this in terms of segments. When you think of these, is break them down and sort of try and understand the needs, for sort of the different severities, the severe, the mild, and so on, because I think that really leads to a solution. It's not, don't look at them as a diagnosis, look at them as sort of a continuum.
Yeah, just quickly, if I could add on to that too. I mean, I think that there's really not enough services for diagnosing people as adults too, because a lot of people didn't get, treatment in childhood, but still have ASD or some sort of like other neurodivergent condition. And it's really hard to find adult neuropsychological evaluators for this, because psychiatrists like really don't like to diagnose this in by themselves, especially in adulthood. And I think there's also like there's also a lot of like Spanish speaking, folks who speak other languages who need this type of service. And I think there's very little of that, especially for adults. So the last thing we're going to talk about are a couple systems issues, like system-wide mental health care issues that we think could be better addressed as well, and that we have some suggestions about. So we'll go to the first one. I'll let Martin take it away.
Yeah, so, one of the things to really think about in terms of a system, if you step back, currently we're constructed really around levels of care. And, even some of the, manuals that are put out around finding right service placement, like those from the American Society of Addiction Medicine, really sort of talk about those levels. But the problem is that sometimes you have to sort of step back and say, is that really the best way to address someone? Because a lot of these are chronic conditions. So rather than thinking of it in terms of level of care, think about it, what is intensity of service? And there are a lot of examples out there, I think, of companies that have innovated. For example, I'm going to use eating disorders. The idea was that if you took someone with anorexia, they had to be treated in a residential setting. there are entities out there that have really stepped back and said, wait, we can take that intensity of service and deliver it in the home and get similar results. I would challenge that that's really the way to think about this. There are lots of these populations that we sort of force into these levels of care that don't quite meet their need, or we end up having sort of access, choke points because there's just not enough beds. Isobel sort of mentioned with tweens or adolescents in crisis, in an emergency room. And then they sit there, waiting around for days or weeks for a bed in a residential setting. But what if there was a way to really take those kind of residential services and deliver them acutely at home for a piece of that population? Obviously, I'm not saying it works for everyone, but it's sort of understanding that, I'm going to challenge the assumption that we have to design programs that really fit into our existing boxes, because they don't work. We have incredible access problems. We don't have enough personnel, and many of them don't exist in many of the states. So if you're looking for specialized services, you're not going to find them in the majority of counties in the United States. One of the gifts out of the pandemic is we really proved that for many cases, virtual care is just as effective. So again, I would sort of put out there as you're thinking through opportunities, is really kind of reframe your frame of reference, around how that could be delivered.
Great points. I don't have anything to add there.
Yeah, that was perfect. Okay, and then we just wanted to touch base on this kind of what seems to a lot of people to be a new area of psychiatry is interventional, but also want to point out that some of these modalities have been around for a long time and actually have amazing evidence behind them. So ketamine, is a newer treatment to get FDA approval. It is given in different ways. It can be given IV or intranasally. And basically the idea is so again, moving to interventional psychiatry, this is an area that has, a lot of interest. There are some newer treatments, but there are also tried and true treatments. So ketamine is newer in terms of FDA approval. It has multiple ways of being given to patients, including intranasally, IV, even intramuscularly. And it is really exciting because the data is pretty good for giving treatment-resistant depression response in a much faster way than typical antidepressants. It also is not very invasive, so it is an appealing treatment and a really exciting treatment. But we think it's important not to miss out on talking about these tried and true treatments. So electroconvulsive therapy, or ECT, unfortunately does have a little bit of a PR problem. A lot of us think about sort of old images or movies like One Flew Over the Cuckoo's Nest, where people are getting this treatment, and it can often feel sort of inhumane, but it's actually a treatment that has many, many years of data, has a very low safety side effects. And it is often really effective for people who have not responded to antidepressant medication. There are, head-to-head trials looking at ketamine versus ECT, but we do have a lot more data on the long-term effectiveness of ECT. But these are both exciting treatments and treatments that we shouldn't forget about as the focus, switches to other things such as psychedelics. We included TMS, which is also an exciting treatment for neuromodulation. So we also have TMS, which is a treatment that's newer. It's another neuromodulation intervention. It has less evidence than ECT, but is also less invasive. And then, of course, we could not have this talk without discussing psychedelics. So, there are a lot of exciting studies going on at different clinical sites across the country looking at different psychedelics, including MDMA, ayahuasca, psilocybin, ibogaine, LSD. And, some of the studies, especially around MDMA, are very exciting. And we're excited that the private sector is, getting ready for potentially FDA approval of MDMA. But we also think that it's important to not forget about these older treatments that have existed for much longer and have really robust data behind them, like ECT. So we don't want, the private sector to forget about these treatments, because accessing ECT in many parts of the country is actually very difficult, even though we know it's one of the best treatments we have in psychiatry. So really important to keep in mind as money is being funneled into the psychedelic treatment.
Yeah, if I can just add, I think, it is exciting that we sort of have these new modalities, particularly, for treatment-resistant depression. The challenge again is really, it's not just about the treatment, it's about how you're going to get the treatment to the patient. And I think that's where you really have to understand, because yes, they're going to come out with these psychedelics, but the patient may need to be supervised for a period of time. And how are you going to do that? How do you set up a model that would be reimbursed? How are you going to sort of track and make sure that there's not abuse or diversion of the drug? These are all sort of challenges. And so again, it's starting to think about holistically, not just the treatment, but the the sort of setting or context in which the treatment needs to be delivered. And really being able to engage and reach the people that could benefit from it. All of those will require innovative solutions.
And Martin, I think that's such a good point about set and setting, because that actually is a lot of part of the treatment of psychedelic therapy. Is it really matters where that work is done. So it's important to keep that in mind, that a large part of these protocols actually involves therapy and also creating a therapeutic setting, which is not always easy to create outside of the clinical trials.
So I'm just going to wrap it on up. So we wanted to include a couple more issues, because there are so many, frankly, like there's still actually quite a bit of white space, I think, in mental health, and mental health tech is still a really nascent field. It's really exciting that now there's a conference that's just focused on this, where we can give a presentation just on the landscape of mental health. But we wanted to list a couple things that we still, like, if this was a longer presentation, we could talk about. And I'll do a couple like call outs here. I still think, as a perinatal psychiatrist and like reproductive psychiatrist myself, I still think like beyond pregnancy, there's actually a lot more to be done around the perimenopausal period for women, and also around premenstrual dysphoric disorder, PMDD, that involves both research and also scaling of treatments that we know work. I also think that people aren't really thinking about gender-based violence perpetration. Like, we know that lots of really unfortunate stats around gender-based violence and sexual assault and all of that. But actually, what are we also doing to help folks who have done some of the violence, right? And help the perpetrators as well, because that's also a big community and public health issue. One call out that we had as well is like the what we call the troubled teen industry. So, as you will probably heard around, like, Paris Hilton coming forward and talking about how she was sent to, a troubled teen camp. There's actually a whole industry around, where to send troubled teens to, and wilderness programs and things like that. And I think that there actually could be, if we looked at that through a mental health lens, we could actually come up with much more effective programs for that population. We also, continue to think about healthcare workers and frontline workers. Even post-pandemic, they're busier than ever, and they're also under as much pressure and stress as they have ever been. And I still think there's quite a bit to do around geriatrics, particularly around like end of life care, like palliative care, also like the management of dementia or like cognitive impairments as well, and at-home services for that population too. Anything else that you two want to point out as well?
No, I mean, I'm sure we've left things off the list because there are so many. I think the bottom line over here is, I know there's been a lot of activity in the startup space around behavioral health, but I think we're just getting going. I think, it's certainly not mature. I think there's lots of opportunity out there. to sort of think through carefully what some of these potential scalable, effective solutions could be.
Well, thank you all for joining us for this talk. I hope we didn't bore you, and we are your friendly neighborhood psychiatrists. So if you have a question or a comment or just want to talk with us about some of these issues, we'd be happy to. Feel free to email us whenever you like.